Regional Anesthesia Workshop, Infraclavicular Nerve Block, and another presentation to the American Association of Child and Adolescent Psychiatry entitled Current Therapeutic Pharmacology in Pediatric Pain Management. Too many P's in this morning's presentations. Another presentation for the American Academy of Pediatrics entitled Interventional Pain Modalities for Children. She has several publications in these areas, including the risks of fixed angle supraglottic airways in infants and an update on complex regional pain syndromes in children and adolescents. So this morning, our presenters will be sharing their thoughts on trauma-informed care in interdisciplinary pediatric pain management. Welcome. Thank you for coming.
Thank you so much for having us and for that very kind introduction, Dr. Fuentes. I will be starting out our presentation. I'm Dr. Banky. Very nice to be with all of you in this learning community. I will be co-presenting with Drs. Baruki and Drs. Adcock. I'm really thankful and grateful for them in joining me in this presentation. We three are actually part of a broader interdisciplinary integrated team here at Children's in San Francisco, consisting of pediatricians, anesthesiologists, nurses, clinical psychologists, myself, chaplains, social work, acupuncture, massage therapists, and many other modalities. And we work really closely together, so featuring our team here. We're excited to share this presentation with you. We have these learning objectives this morning. Hopefully we're able to target each of them. We have no disclosures to discuss today, although we will be, at least Dr. Baruki will be discussing some off-label use. In early November of 2019, the CDC released the ACEs Vital Signs Report. So many of you, I'm sure, are familiar with the ACEs report, and this was a landmark statement. The key findings from this statement highlighted that the broad and lasting impact of trauma on lifelong health and opportunities. It highlighted the pervasiveness of adverse childhood experiences and the heightened vulnerability of women and marginalized racial and ethnic groups to experience compounded ACEs, as well as the general lack of awareness among the public on how ACEs contribute to increased risk for health problems across our lifespan. It's with this understanding that we as a team really try to inform not only ourselves, but our families about how adverse experiences and trauma impact them and how we can improve our care. We're going to highlight a specific case that the three of us work together to support this patient on. And I'm going to turn it over to Dr. Baruki to introduce our patient.
Good morning, everybody. We're really happy to be here. Okay, so we'll start with our case. And then after that, I think everything we discuss is going to basically kind of try to unpack our case and show the lens for which we treated our patient through. So our patient is a 17-year-old male, patient M, we're going to call him. He has a past medical history of urethral strictures and has had multiple repeat penile procedures, including urethroplasty. This has been since childhood and a youth. Recently had a preputial island flap done when we met him. He was post-operative day 7. He had had his procedure, went home, and returned to the emergency room with an ischemic distal penile flap. When we met him, it was a time point of he arrived to the ER. He was met by part of our team, our anesthesia components of our team, and then we met him shortly thereafter. He had an epidural placed in the ED, and he had suboptimal pain control. He then did return to the OR for debridement, penile debridement, creation of a penile urethrostomy, and replacement of his epidural. Post-operatively, he had another epidural placed, and it was suboptimal. And then there were 2 further attempts to replace his epidural to get really good coverage for severe pain. And unfortunately, they were still not covering his pain, and the epidural was removed upon patient request. When we saw him, he was now a couple days into his, I think, 4 or 5 days into his hospital admission. He was post-operative day 4. He had severe pain at his wound site. He was on a hydromorphone PCA, oxycodone, a ketamine infusion, tizanidine, clonidine, ketorolac, acetaminophen, and gabapentin. And we kind of met him and intervened when there was a plan for him to return to the OR for another very large procedure to repeat his skin graft. Next slide. So when we were meeting with patient M, we were trying to basically create a plan for him, perioperative, postoperative plan for this next very large surgery that he was about to go through. And things that he described to us as being traumatic in his hospital stay thus far were, one was the repeat trial of epidural placement. He described those as being extremely traumatic. His initial one was placed in the emergency room while he was awake, and he described that as, to be honest, one of the worst experiences he's ever had. He thought it was very traumatic. He described the ketamine infusion he was receiving for pain. He described that it was very unsettling how he felt at higher doses. He said he felt like he was in he used the quotation K-hole, that he just felt very uncomfortable with that sensation of how he felt disconnected from mind and body. He described marked stress and anxiety with dressing changes. So after his initial procedure, he had repeat frequent dressing changes that were done at the bedside. And there was actually significant concern by the nursing staff at the sedation level dosing that was being used to help get him through these dressing changes, which were extremely anxiety provoking for him. He had marked pain with bowel and bladder elimination. The surgical team actually they actually were promoting him to have penile erections because it improved blood flow to the ischemic area. So he actually was started on medications to cause this. And this is what led to really severe pain for him. And he described that as this as being a very traumatic experience. He had a marked trauma response to the hospital setting. So sound, smells, things like that brought up a lot of painful memories, being held down as a child when they would do procedures. He brought up a concern that he had limited privacy in his room. He frequently, because of the pressure of anything being on the surgical area, he often was ungowned and didn't want anything resting on that area because it was very uncomfortable. And he brought up his concerns with the outward facing windows of the room as to who could see in. He did not particularly want to have a room, as we have in some of our areas, where it faces the courtyard. And also he wanted to make sure that his door had a private entrance. And finally, another trigger was meeting new providers and going to new environments within the hospital. He did find that certain areas he was able to create trust and maybe feel a little bit more comfortable in his environment. And then moving throughout the hospital was a significant factor for him that was concerning.
Thank you, Dr. Brookie. So we'll be using this case to highlight how we as a team provide care from a trauma-informed perspective. I'm going to transition to giving more of an introduction to trauma-informed care as a model and understanding trauma in the pediatric medical setting. So because traumatic events can lead to serious and lifelong medical and mental health problems, pediatric providers are really well positioned to prevent or interrupt the effects of trauma on the development of the child. So in particular, children and adolescents with mental health problems, including those associated with trauma exposure, are more likely to be seen in a medical setting than they are to be seen in specialty mental health clinics with psychologists like myself. ACEs is often used interchangeably with trauma in the literature. So let me talk about a couple of terms. The first study by Felitti in the 90s, ACEs was defined as neglect, abuse, or household dysfunction like parent incarceration, substance abuse, mental illness, or divorce. And additions recently have been death of a parent, community violence, and poverty. You'll notice that some of the ACEs could be discrete traumatic events, but some are not. A trauma or a trauma event is defined as a frightening, dangerous, or violent event that poses a threat to a child's life or bodily integrity, or witnessing an event that threatens the life or physical security of their loved one. This is particularly important for young children because their sense of safety depends on the safety of their attachment figures. Psychological trauma is an intense, recurring, and or prolonged event that threatens or causes harm to our emotional and our physical well-being. And physical trauma refers to a sudden and severe injury that requires immediate medical attention. They include motor vehicle accidents, sports injuries, falls, natural disasters, and many other physical injuries. You notice with our patient M, he experienced both traumatic events, both psychological and physical. In the ACEs literature, it's been established that cumulative experiences lead to unhealthy quantities of stress that contribute to long-lasting effects on the child's brain and body. Child traumatic stress is an umbrella term that refers to the intense fear and stress response occurring when a child is exposed to events that overwhelm their ability to cope, events like ACEs. Many children and their caregivers do exhibit symptoms of post-traumatic stress following a trauma, but only a small proportion will meet the formal psychiatric diagnosis of PTSD. This is a diagnosis that we make when specific criteria about the number, duration, and intensity of symptoms are met as defined by the DSM-5. Post-traumatic stress symptoms can include emotional and physiological distress like disturbed sleep, difficulty paying attention and concentrating, anger and irritability, withdrawal, repeated and intrusive thoughts, and extreme distress when confronted by reminders of the trauma. An important subcategory for pediatricians, and important in this case in particular, is pediatric medical traumatic stress. This is a traumatic stress reaction that children and parents may have to potentially traumatic events experienced in medical settings. Experiences such as pain, injury, serious illness, medical procedures, or invasive or frightening treatment experiences. So how prevalent is child traumatic stress? Well, in a large prospective epidemiological study by Copeland and his colleagues, data were collected on trauma and symptoms from children ages 9, 11, and 13 years, and were followed up annually through 16 years of age. Their results confirm the high prevalence of trauma among children, with a smaller but notable percentage developing post-traumatic stress symptoms. Much like the ACEs studies on stress, this study highlighted that cumulative traumatic events contribute the greatest risk for developing post-traumatic symptoms. Symptoms are predicted by previous exposure to multiple traumas, as well as anxiety disorders and family adversity. Copeland's study was conducted with a normative sample. In pediatric medical settings, the incidence of post-traumatic stress symptoms is believed to be much higher, with some studies identifying over 80% of injured children and their caregivers who experience post-traumatic stress symptoms following a traumatic event. This is why pediatric medical traumatic stress has emerged as a specific area of study within trauma research. Studies on pediatric medical traumatic stress have been conducted with several subspecialties, with cancer and injury dominating the literature. Studies suggest a somewhat high proportion of families of children with cancer endorsing pediatric medical traumatic stress. So we know a lot about the prevalence of ACEs and the prevalence of pediatric pain, but the prevalence of co-occurring pediatric pain and ACEs is still an emerging area of research. So we're still understanding how trauma and pain interact, but it's definitely an important and promising area that we focus on as a team. In one longitudinal study within a national sample of youth beginning at age 4, with final data collection at age 14, children who reported 3 or more ACEs were 9 times more likely to endorse somatic concerns like stomach aches and headaches. In another study, pulling data from a national sample, the authors found that with ACEs, with at least one ACE, there was an additional 21% increase in risk for having a chronic medical condition like chronic pain. In a retrospective study on youth with chronic pain, 80% of participants endorsed at least one ACE, with ACE exposure associated with greater fear of pain. And in a recent study published in Pain Reports last year, Grunwald and colleagues reported that children with exposure to 1 or more ACEs had higher rates of chronic pain compared to those with no reported ACEs, with financial instability, living with a mentally ill adult, and having experienced discrimination based on race, conferring the strongest association. So what we're saying here is that when we're paying attention to past trauma in pain management, that we are both providing trauma-informed care and pain management. They're one and the same. And what we're doing is that we're supporting nervous system regulation. So not unsurprisingly, post-traumatic stress symptoms and chronic pain share critical neural pathways and brain regions, both activated in times of stress. For example, prolonged activation of the HPA axis, systematic exposure to cortisol, and triggering of pro-inflammatory cytokines. In terms of brain imaging, there have been few specific pediatric studies, but there is one prominent study conducted by Simons and her team at Stanford, which implicated limbic and prefrontal brain regions in a sample of complex regional pain syndrome patients. The study focused on pain-related fear, observing greater amygdala connectivity in youth with pain-related fear. As pain-related fear changed, so did connectivity patterns. Similar brain networks associated with trauma symptoms have also been implicated in this way in teens. Importantly, Grace Cow and her colleagues also highlighted that a trauma event history is not always present for all of our patients with chronic pain. But what they've suggested is that persistent re-experiencing of pain in and of itself may serve as a source of traumatic stress. Each time the child or teen thinks or reflects on acute pain flares, a caregiver conducts a status check, or peers are unsupported, the individual experiences sort of micro-trauma, triggering heightened distress and brain reactivity and leading to further exacerbations in pain. So how can we support nervous system regulation as a team and as providers? Really, when we're talking about trauma-informed care, that's what we're talking about, is supporting that nervous system regulation through these key core principles. So how do we create a culture of trauma-informed care? And I know folks here at SFGH do a really good job of paying attention to these factors, but I'm going to go over them again. So to what extent does the institution, the system, promote activities and settings that ensure the physical and emotional safety of consumers and staff? To what extent does the institution and setting promote trustworthiness in the service delivery? Clear, transparent, consistent, and then with appropriate boundaries with their patients and staff. How do the services and settings maximize consumer choice and control, also for staff and patients? And how do the services and settings maximize collaboration and sharing of power between staff and consumers, between leadership, between staff, and among patients? And do the services and settings prioritize empowerment and skill building for consumers and staff? And finally, how is culture, history, race, gender, location, and language acknowledged? And how is that acknowledged in terms of the compounding impact of structural inequity? All of these core principles will be reviewed with this case. So in order to promote trauma-informed care in pediatric populations, what has been identified as important is treating trauma-informed care as a universal precaution. So Ann Kazak and her colleagues at the Center for Pediatric Traumatic Stress created a provider toolkit that's available online for free to support prevention and treatment of pediatric medical traumatic stress. The trauma-informed care model overlaps well with the family-centered care model that we practice in pediatrics, and it suggests that creating systems-level change is possible. Shared elements of both trauma-informed care and family-centered care are included here. Importantly, you'll notice that it includes addressing distress, pain, fear, grief, and loss, integrating approaches into each patient interaction, sharing information with patients and families, encouraging family presence when possible, providing choices, considering family needs and strengths, providing care in a culturally competent way, collaborating with and across medical teams, and attention to provider self-care as well. They've also provided us, Ann Kazak and her team, with a handy acronym to remember with each patient interaction, the DEF protocol. This involves remembering to reduce stress, assessing and managing pain appropriately, asking about fears and worries, providing emotional support within therapeutic relationships. So who and what does the patient need? And remembering the family's strengths and stressors, and providing support to the family as well. Aside from universal precautions, there are some effective and helpful evidence-based targeted interventions that have been developed. I'm not going to go into depth with them today, but I do list them here. These are examples that show promise by focusing efforts on optimizing pain control and minimizing distress. These interventions serve to mitigate the potentially traumatic events that pain and other medical procedures can have on our patients, and help to show how reducing perioperative anxiety, especially for children with chronic illness, have when they have repeat procedures like our patient M. So I'm going to turn it over into Dr. Adcock to share with us how she incorporates this model into her integrative therapies.
Great, thank you, Dr. Benke. So you can go to the next slide. So I want to talk a little bit about the integrative therapies that we use. We use a lot of them on our team. Here's just a short list of them. So acutherapy, which is how we've renamed our acupuncture service, in part to reduce the trauma of the word puncture. Not a great word in a pediatric population, so we call it acutherapy. Massage therapy, aromatherapy, clinical hypnosis, biofeedback. We use different electronic stimulation devices, including TENS units and relief bands, which are for nausea and are put onto an acupuncture point that's well known for nausea. And we partner with our child life services. So a lot of these therapies, although we use them for different types of symptom management, first and foremost, most of these target the nervous system. And we're going to keep hitting that home as a way to provide good care in a traumatized patient, or really any patient in general, is to stay mindful of their nervous system and figure out how to engage their parasympathetic system, which is a large part about what I do as an acutherapist, as a doctor of Chinese medicine. Benke, you can go to the next slide. Thank you, Dr. Benke. So let's bring it back to our patient. So I get, in rounding, I hear about this patient. This patient comes into my service, and I hear what's happening with this patient with pain management. And I think, okay, there's a lot that I could potentially do to help this patient through their trauma at this moment, through their pain, through other symptoms they're having, as well as provide support for upcoming procedures. So the patient presents with high levels of pain, nausea, and anxiety. These are all areas where acupuncture and acupressure medicine can be very effective. Some of the pharmaceuticals were creating side effects, especially the analgesics. He was having the K-hole experience with ketamine, and some other concerns with sedation using benzos and opioids. He was having tons of nausea, and the antiemetics were not effectively managing that. It was also clear that this patient had quite a bit of existential and emotional pain that was presenting in his case, and that was triggering amplification of his other symptoms. And he also presented as hypervigilant in the room. He was reporting sensory overstimulation. These are often tied to trauma. The smells and the sounds, particularly of the beeping machines and the smell of the hospital, especially detergents and cleansers, were triggering for him and reminding him of past painful procedures and admissions. And his mom pulled our team aside in the hallway and talked about how the patient was having flashbacks and experiencing these triggers. And anytime that would happen, how nausea and pain would then escalate. So what's true is that acutherapy can help treat a lot of these symptoms and address some of the underlying trauma. So I want to talk to you a little bit more about how that works. Next slide, please. So acupuncture, and I've done lectures on acupuncture medicine itself. I'm not sure how many of you are exposed to acupuncture. I did a grand rounds for UCSF for Benioff Oakland in August if you want to learn more about acupuncture medicine. But here's a quick overview. So acupuncture and acupressure in varying degrees. Acupuncture is a stronger dose of the same medicine, acupressure a little lighter dose. But all of these techniques encourage parasympathetic activity. This is good in patients that have trauma or experiencing any symptoms. Also, it's been found to trigger spinal reflex effects. So it helps local muscle tissue to relax. It can also change the way visceral organs are functioning. Acupressure has been found to change the functional brain connectivity. So it can help decrease any activation of the limbic network, which is commonly triggered with trauma. And this helps increase coping and resiliency. And it also helps regulate the HPA axis, among other things. So acupuncture already is targeting some of the things and the responses that we commonly see in a stress response or trauma response. Next slide, please. So on top of all of that, acupuncture has been found to release endogenous opioids. This is why it's so good for dealing with pain. And that's one of the ways acupuncture medicine is making its way into Western settings as an additional pain management tool, a non-pharm pain management. I'll tell you, it does so much more than that, but if that's the open door we're coming through, then great. Let's see how much we can do with pain with acupuncture and acupressure. So enkephalins, endorphins, dynorphins, endomorphins, nociceptin, among many other endogenous opioids that have been linked to be increased with acupuncture delivery. Next slide. And all these stress chemicals that get triggered in a trauma response, all of these are connected to studies. Acupuncture helps to regulate these chemicals, so it can help to mitigate a traumatic stress response or other symptoms in patients. Next slide. I want to talk to you guys a little bit, just to give you a little bit of an integrative medicine perspective. This is a lot how our team works. We are an integrative team with practitioners from so many different disciplines, and we get together, we talk about patients, and we do it from our unique point of view. And when treating pain, and especially when treating trauma in a patient, I want to talk to you about the concept of the Shen in Chinese medicine. The Shen it's an overreaching concept that is deeply connected to what you might call the spirit, the mind, or consciousness of a patient. It really encompasses many different aspects. It is not apples to apples with Western thinking. So it represents the mind. It's about self-expression. It's about the state of mind that I'm in this moment. My Shen also guides my life's purpose. It interprets meaning from every conversation I have and every interaction I have. My Shen is the filter through which I experience the meaning and context of my life. My Shen needs to be cultivated for me to reach the full potential of my life. And many will say that acupuncture medicine and Chinese medicine is about just that, helping patients to reach their fullest potential of what they could be in this lifetime, what they've come here to do. The Shen is witnessed in the eyes. It's not unlike the affect, although it's so much more. And it's something that we know when we make eye contact with a patient, and that's not always possible with our patients, we know this, but when that happens, you can probably stop, and you can feel this with animals and experience it with animals as well, that there's a certain connectivity and a recognition of person to person, Shen to Shen in an engaged eye contact where there's presence on both people's part. Chinese medicine gives a lot of personality to the organs. There's no separation of the mind from the organs. Each organ presents with its own piece of our mind and its own piece of our spirit, creating the whole. So the Shen is said to reside in the heart, which is more where we consider people to be, is in the heart rather than in the brain. So it has a lot of heart connection, and any time that there are heart symptoms, palpitations, or anything from a cardiology point of view, there is often a disturbance in a patient's Shen, which will present as agitation, among other things. And the Shen is nourished by the blood. So the health of the blood helps nourish this sense of the spirit. So this is a kind of different integrative concept, but I want to throw this out to you guys because it's interesting, especially when dealing with trauma and considering it. Next slide. So the Shen also, each organ is having its own experience and contributing to the whole. However, the heart and the Shen within the heart specifically are filtering everything. So the heart and the Shen are communicating with all of the other organs. So anytime an organ is in distress, it is still channeled through an experience of the heart and the Shen. So the Shen is this kind of, they say it's the emperor, the empress of the whole kingdom of the body. So any symptom that's happening is affecting the person's overall Shen and their way they're perceiving their situation. Likewise, if you can calm the Shen and ease the Shen, it helps to ease any other symptoms or distress that other organs are having. Next slide, please. These are just some aspects of what the Shen provides. It provides a unity, which is a congruency of all of our different personalities and our organs. The Shen provides awareness of the self and also of others. And it's also the ability to connect with a Shen of a patient helps to indicate the prognosis of how much that person will engage in therapies with you. The Shen provides clarity of thought process and logical actions and stable actions that follow that. The Shen provides balance of a person, giving them the ability to express a full emotional range, but not to dwell in any one emotion and get stuck in that place. So a balanced Shen helps to create resiliency in a patient. And the Shen also powers the patient. It gives them power to meet their life and to engage in their world. So this is a pretty broad concept, like I said. Next slide. So you see the different Shens in these young adolescent patients here. My first day of medical school in Chinese medicine school was one of my teachers saying, simply touching the Shen is a treatment in and of itself. So when we're connecting with our patient, if we can have that eye-to-eye contact, if there can be that presence in our eyes and our intention and be met with them, that already a treatment has started to help relax the nervous system. The patient feels heard and feels met and already start to downregulate some of the stress responses that you see. The eyes brighten. Look at this last baby. The eyes are bright. This is often what I see at the end of an acupuncture treatment. It's wonderful to watch the eyes brighten up. You've probably seen it if you've had a massage. You go look in the mirror at yourself afterwards, your face and your eyes are brighter. This is something that's often witnessed with acupuncture treatment. And when we're able to calm the Shen, we see a direct correlation with engagement of the parasympathetic nervous system. These concepts are one and the same. And that I often notice when this event has happened, a patient will take what I call the big breath. And you may have noticed this before, you may have felt it before in yourself when you're getting a massage or another type of manual therapy, or when you finally feel like you can relax after a stressful moment. There's this big diaphragmatic breath that happens. You can hear it in the room, everyone in the room can feel it, and this is a good moment. It means that you've started to turn the system around in the patient to help their nervous system work for them rather than against them. Next slide. So this patient that comes to me, he has all these reasons that he would be a great candidate for acupuncture. There are these clear barriers, and there are many barriers that can happen with acupuncture medicine in a pediatric population. Many of them also include awareness of it, exposure to the therapy, education levels. Race has been shown to play a role in who will or won't expect or engage in integrative therapies. So we have many psychosocial barriers that happen. These are specific to the case that I noticed. One is that the patient, when it came to my service, had very high acute high symptom burden, high pain, high anxiety, high nausea. This is not often the easiest time to initiate a new therapy that a patient has not been exposed to before, especially one that involves therapeutic touch. So that can be challenging. Also, the patient was experiencing pain in a very private area. This is a genital surgery. And so the patient already had concerns that local access would be required for pain management. And the patient had no previous experience with acupuncture or acupressure, so wasn't sure what to expect from the treatment or the methods that would be used. Next slide, please. The patient also had past experience with needles that were traumatic, and this is true. This is one of the most painful experiences and traumatic experiences that pediatric patients report is IVs and shots and other needles that they're exposed to. So it's not easy for me. I'm always coming in with a trauma-informed approach to help patients have a different relationship with needles. Usually after a treatment or two, they feel very differently and don't see what I use as needles and won't put it in the same category. However, it takes a staged trauma-informed approach to be able to introduce this therapy to patients and their families who are not quick to accept more needles as part of their treatment course. This patient also had memories of being held down for procedures as a child. So any type of downward pressure on his body was also triggering, which could be a barrier for acupressure or massage. And the patient also had past experience of medical mismanagement, and so was not open to welcoming in or trusting new providers, especially ones that had to touch him. So these were some of the barriers we had to work through to be able to try and provide integrative medicine. Next slide, please. So some of the things that I did, first of all, I mentioned I already removed the triggering language. We don't call the work acupuncture, we call it acutherapy. And I've really developed a lot of tools that are not focused on the needle. Some of them are using my hands for acupressure and other acupressure tools, including special trainings in Japan that I've attended to try and figure out ways to stimulate acupoints that don't involve needles. And so we've been able to expand our service to a much larger population range here at the hospital, including neonates, because we're able to do these therapies without introducing invasive procedures that involve needles. However, we do use needles and other therapies as part of the acutherapy service. I also always explain the treatment before I do it. I unpack what a treatment's going to feel like, what it's going to, the experience of it, the duration, the time, the places that I'll need to touch, exactly what I'll be doing. I unpack that with patients before moving forward so they understand what they're getting involved with. I also make it very clear that it's not like they're getting on a roller coaster ride and can't get off. I help patients see that maybe I'm driving the car, but they have their foot on the brake. So at any point they can stop the treatment, slow the treatment down, or decline parts of the treatment while accepting other parts of it. And I reinforce this every time I see patients. Hey, if I'm about to put a needle here and you don't want it, you let me know. And I'll say to patients, the more comfortable you are for our treatment, the more effective it's going to be. So anything I can do to help you be more comfortable will make the treatment more effective. You won't be hurting my feelings. And I tell you this often, just even stating that will initiate the big breath in patients. They hear that and they'll go, and they already start to feel more relaxed. All right. So I also will often ask patients to inquire about preferences, giving them choices. Would you like this tool or that tool? I could do this point or that point. Do you have a preference? Always doing that at an age appropriate level. I always ask permission to touch patients before I touch them. May I touch your head? Is it okay if I touch your foot? So asking permission gives patients back control where they feel they've lost it, especially if there's been trauma. And I offer a lot of check-ins, and I always, again, put the child's comfort first. And if I see they're getting nervous or their muscles are tightening up or their breath is getting shorter, then I alter what I'm doing. So I'm staying in touch with them the whole time through the treatment. So these are some of the ways we've applied trauma-informed care and these principles into the acutherapy service. Next slide, please. So I'm going to skip some of this just for the sake of time, but it's just good to remember that less is more with kids. I'm lucky to get to do an additional therapy with them, but I always try to not do too much at one time and stage things and look for an entourage effect of treatments to build up over time, and always focusing on patients' calmness and wellness. Keep going. Next slide. Thanks. And just remembering that when patients feel heard and listened to, it often helps to already downregulate a trauma response. So whether that's being listened to verbally when we ask them questions and mirror back what they're saying and repeat back so they know we've heard them, or if it's listening with hands and manual therapies, that's often a way to deliver a sense of being heard to patients that aren't necessarily verbal or aren't connecting in that way. So touch or mouth and talking are ways for patients to feel heard. Next slide. I'm going to just keep going because I want to make sure Amber has a lot of time to talk. So can we just move one more ahead, Becky? Thank you. So these are some of the tools I was talking about, where I use tools to stimulate acupoints that do not involve puncturing the skin. However, it's good to remember acupuncture needles, that's a hypodermic needle. You can fit about 30 of my needles inside a hypodermic needle. It's always good to show patients these little tiny needles for acupuncture before they accept the service. And next slide. Different levels of stroking and touch affect the nervous system differently. So I just want to remind us, when we're talking about massage, acupressure, acupuncture, or any other manual stimulation of patients, whether that's even palpation, we are triggering patients' nervous system at different levels depending on the rate we touch them, the rhythm, and the pressure. So it's good to keep in mind that touch is a language of communication, and that the nervous system has different levels, and we can create different therapeutic responses by just engaging the cutaneous layer of patients. And next slide. And I just want to talk about one last thing. So this is what I did with this patient. So here's this patient. He's having tons of anxiety. He's having tons of pain. He doesn't really want to be touched anywhere. He's using a device with his hands, doesn't want to have his hands stimulated, doesn't want to be pressed down upon, and is not open to needles on the first treatment. So where do I go with that? What I did is I took a touch tool and I started stimulating points on his ear. And the ear is a wonderful way to engage the peripheral branch of the vagus nerve, but it's also so much more than that. So there's a sample of a probe or a touch tool that I use simply to start the treatment there. So this patient would start to see the benefit of what acutherapy could do. And next slide, please, Dr. Benke. The ear is very complex. Simply put, it's an upside down fetus. This is a model that was developed in the 50s by a French MD and acupuncturist, but the ear has over 200 points and is a very complex microsystem of the body that can be used for wonderful acutherapy stimulation. And the next slide, I want to highlight a treatment that was created, and this is an auricular acupuncture or acupressure treatment for the ear, 5 points, that was developed simply to treat trauma, pain, and addiction medicine. Was created in the 1970s at the Lincoln Detox Clinic. It was the first outpatient methadone clinic in the country. And they're providing methadone to help the local community to get off heroin. And they added in acupuncture medicine. And I want to credit and make sure that the Black Panthers and the Young Lords get credit for creating this program as a way of fulfilling the needs of their community and creating what is now the most highly researched acupuncture protocol that has been researched and delivered for the past 40 years. So this protocol, let's go to the next page. This is a 5-point protocol that is one of the best ways from a public health perspective that we can treat patients either with needles or with little acupressure seeds that are non-invasive to help with pain, nausea, other symptoms, as well as to treat the effects of traumatic stress on patients. And this is a program that has been provided training to over 2,000 different health programs in the country. It's standardized the way it's delivered. It's been researched, and more than 25,000 healthcare professionals of all disciplines have learned this. It's safe, it's affordable, there's no side effects. So I want to highlight the NADA protocol as the way that I opened up with this patient. Eventually, and you can go to the next slide, Dr. Benke, he became open to acutherapy service. He went on, this is by the way, a podcast about this revolutionary medicine and the Black Panthers and the way that it was an act of rebellion to take back control of medical care for the community and to find affordable, effective medicine to support this Bronx community of patients, provided for patients. So this is a really good podcast if you're interested in this line. And next page, Dr. Benke. So just more information about NADA, and next slide. And this is a study that showed how just one of these 5 points was delivered to healthcare providers at the University of North Carolina. And so they had several hundred people come in and just once a week have one seed placed and found that it reduced burnout. So this is not only good for our patients, this is good for us. And we're looking at ways to implement this therapy for providers at the hospital as well to broaden exposure to this intervention for all of our patients. It can be done safely at home. And applied easily. So I just wanted to share that. So that's what happened with this patient. I started in with the ear acupressure. Eventually, he opened up to more, started receiving acupuncture and acupressure all over his body. He found that he could tolerate the needles of acupuncture as long as we started engaging in safe acupressure at the same time. This patient wanted to receive daily care as possible, and then came to see me in an outpatient clinic over the next few months and became a huge fan of acupuncture medicine, continued to see benefit for pain management and reduction of stress and anxiety, insomnia, other symptoms. And acutherapy was included at the very beginning for all of his future admissions as part of his pain plan. So we were able to convert him from being afraid of needles and touch to being a huge fan, receiving tremendous benefit from this. And I think that's it. I'm going to turn that back over to you, Dr. Barucki.
Thank you. Thank you, everyone. So just to get back to the case and kind of the trauma informed care and pediatric pain management lens that we looked at this case. So next slide. Just again, want to reiterate what Dr. Benke's prior slides had said. The importance of examining childhood adverse childhood experiences, and the importance of looking at that with patients that present with pain. Studies that have been finding that at least, these patients are presenting that at least 50% of patients are exposed to one adverse childhood experience in lifetime, that there's a significantly higher rate of chronic pain in patients that are exposed to adverse childhood experiences. And then there's a dose dependent fashion. So as more adverse childhood experiences, you're going to see more pain in patients in there as a child. And then I have a slide in a minute that'll show you also as an adult. It impacts adults later in life. So there, again, Dr. Benke had shown a study about this retrospective study looking at 141 youth with chronic pain, and that 80% were found to have at least one ACE. Their patients that had an ACE exposure had greater anxiety, depression, and fear of pain, and greater than 3 ACEs was associated with the greatest impairment in functioning. The follow-up study to that, done at the same institution, was then taking these patients that were perhaps seen in their clinic, and then they enrolled them in a pain rehabilitation model. So they were included in this pain rehabilitation program. And then they examined those patients and their ACEs. And of the 305 patients that were enrolled, they found that 59% had at least one ACE and 21% had greater than 2. Those with the ACE that had the ACE history, again, reported a higher number of somatic symptoms. Importantly, they found that if someone had an adverse childhood experience, it didn't affect their actual pain treatment, that they were still able to receive benefit from these treatments, the same as other patients who didn't have ACEs, which is good to hear. And then they hypothesized their hypothesis as to why the percentage found with the percentage of patients found with at least one ACE was lower in this treatment group, was that less patients with ACEs had many more barriers to actually get this treatment. So unfortunately, those patients could not enter this pain rehabilitation program. They didn't have the resources, means, they didn't have, their trauma experiences did not allow them to enter into these treatments. Next slide. So then trauma and then adult pain. So a lot of the studies that Dr. Benke and I focused on initially were on pediatric pain, but then let's take a look at adult pain. Well, they actually found that childhood trauma confers a 2 to 3-fold increased risk of later development of pain in adulthood. They did a study in the general population in Germany of greater than 2,400 people. It was a randomized study, and they found that 30% had experienced trauma, and they found that emotional abuse was the most correlated, and that emotional abuse was most associated with widespread pain syndromes like fibromyalgia syndromes. If you look at the graph that I have there up on the right-hand corner that says number of child trauma questionnaire categories met on the x-axis, and on the y-axis overall pain, and you can see how it correlates. So the more trauma categories that are met, the more pain patients reported as adults. And then in the picture below, it's just showing you the different types of trauma, emotional, physical, sexual. And it was found that, again, that emotional abuse was kind of associated with these widespread pain disorders. And so some of the findings of different adult pain conditions like dyspareunia, fibromyalgia, interstitial cystitis, low back pain, migraines, orofacial pain, pelvic pain, pregnancy-related pain, these were all associated with childhood trauma, having increased childhood trauma events. Next slide. So let's talk about the 6 core principles of trauma-informed care and pediatric pain management, and kind of how we can use. I really like the idea of looking at each of these different 6 core principles and then using those to then affect the patient's pediatric pain management. So let's start with safety. So we can first explore, well, what medical treatments has the patient received for their pain, and what treatments, what environments had the patient felt were triggering or unsafe for that patient. And I'm going to get into our next slides. I'm going to go through that for each of these patients. Trustworthy or transparency. So really working to create trust with the patient, to be transparent about how much pain to expect. You never want to tell a child, oh, you won't have any pain, and then they have pain. You have to be transparent in a child appropriate manner to let them know that they may expect pain, and maybe what that might feel like, oh, it might feel like a little, it might feel like a little burn or a sting or etc. I explain, I'm an anesthesiologist. My patients fall asleep. I tell them one of our medicines, propofol, sometimes, and I like to use terms for children, feels like a sunburn on your arm. That might feel, when you feel that, it might feel like a little sunburn if you feel that. But we're here, and I'm going to rub this, and I'm going to let you know when it's happening, and you're going to fall asleep after this, and you're going to be comfortable. Oh, someone says I can no longer see slides from Dr. Benke. I can still see them, however. I can still see them. I'm not sure. Oh, you can see them. Okay. So peer support and self-help. So introduce patients to peers with similar disease process and introduce coping skills. So we do have a significant patient population that we have that will be, certain patients that come through frequently. So we have patients that do that come for what's called a total pancreatectomy islet autotransplantation surgery. And it's a very big surgery. And prior to the surgery, part of the program is we may introduce patients to other patients so they know what the process has been like. They can talk about shared prior experiences, et cetera. So the peer support portion is very important. Collaboration and mutuality. We design a pain plan that's in collaboration with the patient. We use information from their prior experiences, and we do what we can to make sure that the patient's concerns, hopes, needs, wants are met with this pain plan. Empowerment, voice, and change. We allow the patient to express their wishes and changes they think would be helpful to their pain treatment. So it's great if we have a prior experience and we can go off of that and then allow the patient to express what they would like changed. If there's any change they want, express any wishes they'd like for their pain treatment, and empower that patient to be able to feel comfortable speaking up and saying, this, I did not like this, and actually this was better for me. And then finally, cultural, historical, gender issues. So we respect cultural beliefs around pain. So there are patients that definitely have different cultural beliefs, each different culture. Case in point, I had a young patient who was from Thailand who got in a terrible motorcycle accident. He had a degloving injury of his leg, and he had surgery. And afterward, I said, he had very severe, what we call allodynia, which is just any form of touch. It's a non-noise susceptible touch on the extremity led to severe pain. And I discussed this with the patient and said, we can do things to help. And he actually said in his culture that he preferred not to, and that he actually, had been through so much, et cetera. And that pain treatment in Thailand was so different when he initially had his motorcycle accident. He preferred less was more. He did not want more medications, more things, et cetera. So very, obviously respecting his cultural beliefs about how he wanted his pain treated. And then also considering how gender affects pain is very important. There's a lot of literature on how both of the genders, how the prevalence of pain disorders, the prevalence and how pain is processed in either gender, very important. Next slide. So to look at our safety principle, we looked at, we went through each of those different things, and here's some things that we did. So repeat epidural placement, repeat management was triggering. So we avoided another epidural for the next treatment. We said, let's just scrap that. We won't do that. That's too triggering for you. We're not going to do that. He felt disoriented on the ketamine, and he described it feeling like he was in the K-hole. So we worked with his dosing to find where he felt his comfortable level, where it wasn't affecting him. Dressing changes that were painful and traumatic, we made a plan. Let's have him go to the pediatric intensive care unit after the procedure. That way, if he needs to have sedation for this really painful dressing change, that we'll be able to provide it in a safe manner versus on the floor where we were unable to provide it there in a safe manner. He had concern with privacy, so we communicated to the ICU staff and asked them, what type of private room can he have? Can it not be associated with the courtyard? Can we make sure that he's has privacy, because he may be ungowned at certain points, and maybe have communication around that. And then monitors making noise was concerning. So we talked about how can we silence some of the monitors to him in the room, but still have them accessible to the nursing staff. Next slide. Trustworthiness and transparency. Our team worked closely with patient M. We visited multiple times. We listened very closely to him and his family and their concerns. We decided that what a different hospital location would be best, which was the PICU. And we introduced patient M to his new care providers. So before he came, we had nursing staff, and we had the pediatric intensive care unit fellow come say hello, introduce themselves. They're now a friendly face when the patient reaches the pediatric intensive care unit. So that helped with some of the trustworthiness. We gained intel from the surgical team about how painful they thought the procedure might be, which they felt was quite painful. And we disclosed this in a way to the patient as to kind of what they thought the pain from the procedure might be. And then we obviously followed that up with how are we going to treat this? We gathered information about what recovery would look like post-operatively, any potential issues. So strict bed rest was an issue that the team brought up. And then also the surgical team did a plan to use Viagra to enhance blood flow to the graft. So we did disclose that to the patient, so he was prepared of what to expect. Next slide. Peer support, mutual self-help. Unfortunately, due to timing issues, we weren't able to connect him with another patient for peer support. Again, in some of our patients, we do that. Two of our team providers began seeing patient M to discuss self-help treatment. So Dr. Banky began seeing patient M and introduced some cognitive behavioral therapy and coping skills. And Dr. David Becker began seeing patient M and added additional mind-body techniques. And of course, Dr. Ra then added in some additional breathing techniques. Our child life team was involved and worked with patient M on coping skills during dressing changes and procedures as well. Next slide. Collaboration and mutuality. We met with patient M. We collaborated to create a pain plan that he felt comfortable and confident with. We discussed that we'd go to the ICU postoperatively, where we'd have close nursing and staff support and ability to receive sedation if needed for dressing. We discussed that we'd trial intraoperative lidocaine infusion to be started by the anesthesia team and continued into the PICU, and the patient agreed and felt that that was a good plan. We decided to rotate his opioid PCA to a fentanyl PCA so that he had more immediate responses when he had the sudden painful erections after the procedure. We continued his ketamine infusion, but we continued him at doses lower than 4 mics per kilogram per minute. We reviewed current medications and we removed those that were not working. We didn't want to have polypharmacy where we didn't need it. And we discussed that if with this plan he still had pain, then we would together consider doing a procedure if needed. Next slide. Empowerment, voice, and change. So we provided a lot of patient education about pain processing, clear expectations around surgery recovery. We actively asked our patient to voice his opinions, concerns, and feedback. In engagement, we encouraged him to be active in his pain treatment. So most importantly, I think the education piece. Next slide. Finally, our patient had gender-specific concerns about his pain and his recovery. He requested to have periods of time we could be ungowned due to comfort. There's less pressure on sensitive areas. He requested to be in a room without windows to the courtyard. And we discussed sensitive issues such as the urology team's plan to provide Viagra with him that were very specific gender-related pain issues. Next slide. So I just want to round this out that the medical team really, I feel, in this case, we were a leader for his trauma-informed care. And I feel that the medical team should really lead efforts in trauma-informed care. We should work on promoting patient empowerment and creating a space with all our patients that help them feel empowered to help direct their pain care. Listening to the patient, finding their past experiences, hearing their choices, concerns, wishes, and hopes for their pain care. Very important. And then very, very important is the communication then to the patient and to the other teams. So educate the patient about pain processing, very important. Set real expectations about the pain plan, about the pain and the recovery, and then set expectations of other teams in what your patient may be able to do and how they might feel. So sometimes your patient may give me a lot of information about their prior experiences that the surgical team may not be aware of. Very important to then communicate that to the surgical team so they're aware. Actually, previously, the patient felt this. And then finally, communicate plans to the other teams. So as you can see, we talked to the ICU team, the nurses, the staff, everybody that kind of ended up being involved, and we pulled them all into this big plan for this patient and communicated very effectively. Last slide, I think my last slide might be on case continuation. So in transition to outpatient care and return to the operating room 6 months later, the patient saw Dr. Becker, Dr. Adcock as an outpatient. Pain was addressed in trauma from November 2020 to April 2021, and there was constant integrative medical therapies provided, medicine therapies provided. All of a sudden, we were told that a planned surgery would be happening, another big surgery. So we re-met with the patient. We went over the last surgery, went over the last hospitalization, and reviewed most recent pain issues. We collaborated. We reviewed the plan with the pain team, the surgery team, and then we co-created a care plan. We gave sign out from inpatient to outpatient and teams inpatient, and we coordinated with multiple providers and specialists. And patient M did really, really well. He did great. We didn't have his pain was very well managed. His trauma was well managed. And so we actually had a really excellent outcome for this patient on his return. Next slide.
Thank you, Dr. Bricky. We're actually past time, so I'm going to leave you here with our summary and takeaways. Apologize for going over, but please message us, email us with any questions that you might have. We're happy to field those separately. And if you're able to stay on and ask additional questions, we can do that, but we're also happy to kind of end here.
Thank you very much for your offer, and anyone who wants to stay on, please do. Thank you so much, colleagues, for educating us on this very important topic. Happy Tuesday.
Thank you.
Hi, good morning. This is Alma Martinez. I have a question about access to services like this for the patients that we take care of at San Francisco General. I couldn't help but think, oh my God, all these amazing services, and how can our patients benefit from what you've presented today?
That's such a great question. I'm actually going to let Dr. Bruch kind of jump in first, and then maybe Dr. Adcock can speak to how to advocate for integrative services within the hospital setting.
Yeah, I'm trying. Are you, I guess the question being, as an outpatient, are you talking about outpatient or inpatient care?
Oh, I'm just talking about patients in general, and everything that you talked about today, just, it sounded like I've never heard of any of our kids here at the hospital, inpatient or outpatient, getting these services. And so I wonder about access for them.
Well, outpatient, we always have, we have our outpatient pain clinic, our outpatient IP3 clinic. So there's always, you can, in terms of pain care, we do have an outpatient clinic that is composed of all of the similar core tenets that we have inpatient. So we have integrative medicine, we have Dr. Banky, we have our physical therapist, we have four pain physicians, we have nursing staff, we have a social worker. So we've got all of this in our outpatient clinic. So, you can always place a referral to have if there's a concern, to have a patient seen in our clinic. How do I interface in other places where it's not Mission Bay Children's Hospital? So I do interface with Oakland Children's Hospital, Oakland. I've interfaced with there in so much as patients that have come through our clinic, and I've gotten to know, so I work with Dr. Steve Long at Oakland, who will, if he sees patients with difficult pain in the hospital there, he will refer patients to my clinic. If they have upcoming procedures, et cetera, we'll do our best to communicate in that structure, in that hospital system, as much as we can, suggestions for pain. So, for other patients that I've had, I've tried to then reach out to the surgeons there, or some of the other team members, et cetera, to try to get a plan together then when a patient does come in for a painful procedure. So we've kind of tried to, our clinic is kind of the home base, and then we can talk and communicate to the other locations. Obviously, in hospital, getting those in hospital at different locations is a lot more difficult. But the coordination and collaboration, definitely our clinic has worked with in the past in other institutions. It's obviously much easier at Mission Bay, at Children's Hospital Mission Bay, because I can talk with care providers very easily, but we do reach outside of there and have worked with patients in Kaiser. I've interfaced with different Kaiser locations as well to try to affect change and suggestions for a pain plan there as well. Does that answer the question somewhat, Alma?
And I was going to just address it from a different point of view, which is that I think our integrative team was started in 2008 even, and some of that was by 2 MDs that were also practicing medical acupuncture. And it's taken a long time for our team to develop in the way that it has. It's taken a lot of philanthropy and foundational work. And part of our goal is to show that integrative care should be standard of care, and how we work with insurance companies and other ways to fund these programs and providers to provide a more robust service. There are also a lot of therapies that come from our service that could be done by nurses and can be done by MDs and can even be done by patients themselves in terms of self-care, acupressure and self-care massage, TENS units. So I think really one of the focuses for our team, knowing that we have limited number of providers to do this, is focusing on education for other providers in the hospital that are interested in doing some of these techniques, and also education to our patients and their families. That's a big piece of what I do. And integrative therapies, so many of them are safe, so that patients can do this, and parents are often very empowered, and adolescent patients are very empowered to be able to do some of these techniques with themselves, especially coming out of the integrative medicine service specifically. So there are pieces where, you know, there's really highly specialized services that our team is doing. There's also other services that through education could be spread more broadly, and we're figuring out how to make that happen for our patients, and hopefully in programs that could be repeated on other campuses at other centers.
Thank you, Dr. Adcock and Dr. Brucke. I'll just add, I think, so I've been doing work in trauma for the last, I would say 20 years, even before graduate school. And really what I've seen across organizational settings is having a champion, as Dr. Brucke mentioned, for implementing trauma-informed care practices. So if you have a physician or a nursing manager or another leader at your institution that agrees that this is important, that's going to spread into the rest of the providers they surround in their specialties, and services, more specific specialty services will follow. And so I am super grateful to Drs. Brucke and Drs. Adcock, because they both are very much champions within their specialties and have helped to spread the message and broaden services. And so that takes time, but it really is, it takes those leaders and their commitment to the cause.
Alma, does that provide some information? Is that helpful at all?
Yes, and yet I wonder, like, how many of our patients ever come to your clinic? I'm guessing from your talk that you're based at Osher. Is that correct?
We're actually based in Mission Bay.
Oh, you're based at Mission
Part
Bay.
of the SF Children's Hospital.
Okay. Anyway,
I feel like
it really depends on the referral from SFGH. So I actually can say that I have one specific. So if a patient has come here for rehab but was initially seen at the general, we've seen a lot of those patients. And so I still see one of those individuals. So it really just depends on whether or not your providers are referring them to us.
Yep.
okay, thank you.
We just need a referral order.
Okay, thank you. I am going to have to leave, but thank you very much. And thanks for answering questions too.
Thank
Bye.
you. Thank you for the important question.
I'm going to run to morning rounds too. Thank you, everyone. Have a great Tuesday.
Thank you, Dr. Adcock.